Welcome to Dr. Balga's podcast for the Curious Doc. Today is 14 March 2026. This video is on a guideline accepted just yesterday, published online, free access on 13 March 2026, titled 2026 ACC AHA Multisociety Guideline on the Management of Dyslipidemia. It's a report of the American College of Cardiology and the American Heart Association Joint Committee on Clinical Practice Guidelines. There are several authors. The lead author is Dr. Roger Blumenthal from Johns Hopkins. What condition does this guideline address? It addresses evaluation, management, and monitoring of dyslipidemias, including elevated cholesterol, hypertriglyceridemia, Lp(a) to reduce atherosclerotic cardiovascular risk. When should lipid screening begin in adults? Screening with the lipid profile should begin at the age of 19 years and be repeated every 5 years with more frequent testing in individuals with additional risk factors. Should lipoprotein A or Lp(a) be measured? Yes. Measurement of Lp(a) at least once in all adults is recommended to identify individuals at higher risk of atherosclerotic cardiovascular disease. Which risk calculator is recommended for primary prevention? The Prevent equations are recommended for estimating 10 and 30-year risk of atherosclerotic cardiovascular disease in adults aged 30 to 79 years. What LDL cholesterol reduction is targeted with statin therapy in primary prevention? Moderate intensity statins aim for a 30 to 49% reduction in LDL cholesterol, whereas high intensity statins aim for at least 50% reduction. When is coronary artery calcium testing useful? Coronary artery calcium scoring is recommended in intermediate or selected borderline risk adults with the decision about lipid-lowering therapy remains uncertain. What LDL cholesterol is recommended in very high-risk secondary prevention? A target LDL cholesterol below 55 mg per deciliter and non-HDL cholesterol below 85 mg per deciliter is recommended for individuals with a very high risk of atherosclerotic cardiovascular disease events. How is severe hypercholesteremia defined? Severe hypercholesteremia is defined as LDL cholesterol equal to or greater than 190 mg per deciliter and requires intensive lipid-lowering therapy. When should ApoB measurement be considered? Apolipoprotein B measurement is reasonable when triglycerides are elevated, LDL cholesterol is very low, or residual lipoprotein risk is suspected. Are dietary supplements recommended for lipid lowering? Routine use of dietary supplements to lower LDL cholesterol or triglycerides is not recommended because evidence of benefit is limited or inconsistent. What lifestyle measures are emphasized for dyslipidemia management? Heart-healthy diet, regular physical activity, weight management, adequate sleep, and avoidance of nicotine products are core lifestyle strategies. When should a referral to a dietitian be considered? Referral to a registered dietitian nutritionist is recommended for individuals with severe hypertriglyceridemia to reduce triglycerides and pancreatitis risk. What's the role of statins in diabetes without atherosclerotic cardiovascular disease? Adults aged 40 to 75 years with diabetes should receive at least moderate intensity statin therapy to reduce cardiovascular risk. How are patients with familial hypercholesteremia managed? They require early and aggressive lipid-lowering therapy, often including statins plus additional agents such as ApoB or PCSK9 inhibitors. When should genetic testing for familial hypercholesteremia be considered? Panel-based genetic testing may be useful in adults with LDL cholesterol of at least 190 mg per deciliter without secondary causes. How should elevated triglycerides be approached? Lifestyle modification and statin therapy remains foundational, with additional triglyceride lowering therapy considered for severe elevations. What therapy is recommended for familial chylomicronemia syndrome? ApoC3 inhibition such as olezarsen is recommended alongside dietary therapy to lower triglycerides and prevent pancreatitis. How should dyslipidemia be managed in patients living with HIV? Adults with HIV aged 40 to 75 years on stable therapy should receive statins to reduce first atherosclerotic cardiovascular disease events. How are cancer survivors managed with respect to lipid therapy? Cancer survivors with life expectancy greater than 2 years who qualify for lipid-lowering therapy should be treated similarly to individuals without cancer. Why is early treatment of dyslipidemia emphasized? Reducing lifelong exposure to atherogenic lipoprotein lowers cumulative cardiovascular risk and prevents atherosclerotic disease progression. It's the concept of cholesterol years, where the concept is that if your cholesterol is elevated over several years rather than a few years, you're more likely to get atherosclerotic disease progression. What about Indians from the Indian subcontinent and dyslipidemia? As we all know, South Asian ancestry is identified as a high-risk demographic group and is considered an atherosclerotic cardiovascular disease risk enhancer. People from the Indian subcontinent have the highest proportional cardiovascular disease prevalence and mortality within Asian populations. Elevated Lp(a) or lipoprotein A contributes substantially to myocardial infarction risk in this population. Diabetes and cardiometabolic risk factors frequently occur at lower body mass index and waist circumference, probably because Indians have lower skeletal muscle mass. Lifestyle and dietary counseling should be culturally tailored to improve adherence and cardiovascular risk reduction. So the key takeaways: South Asian ancestry is considered atherosclerotic cardiovascular disease risk enhancer and should prompt early lipid risk assessment. Clinicians should consider early initiation of statins in South Asians with borderline or intermediate risk. Measurement of Lp(a) is particularly relevant because elevated levels contribute substantially to myocardial infarction risk in South Asians. Diabetes and cardiometabolic risk frequently occur at lower BMI and waist circumference in this population. LDL targets follow standard risk categories, greater than 50% LDL risk reduction with statins, and less than 55 milligrams per deciliter in high-risk atherosclerotic cardiovascular disease. There's an accompanying editorial written by the guideline authors, Dr. Blumenthal and Dr. Pamela Morris. The editorial perspective in JACC was titled "Moving at the Speed of Science." It goes on to say that these ACC guidelines are rigorous, transparent process, including literature review, expert consensus, peer review, and society approvals to produce clinically trustworthy recommendations. Scientific discovery often outpaces guideline publication timelines, highlighting the need for flexible and rapidly updatable guideline frameworks. The Vesalius-CV trial, which enrolled 12,257 individuals, showed that evolocumab added to statin therapy significantly reduced major adverse cardiovascular events in high-risk patients without prior myocardial infarction or stroke. Evolocumab lowered LDL cholesterol by 55% to a median of 45 milligrams per deciliter and reduced the 3-point MACE, that is major cardiovascular events, and 4-point MACE over 4.6 years. These results suggest that future guideline updates may favor a unified LDL cholesterol of less than 55 milligrams per deciliter for many patients with atherosclerotic cardiovascular disease or high-risk diabetes. In fact, I tell many of my patients above the age of 50, ideally they should have 5 million in their retirement account. Their LDL cholesterol ideally should be less than 55 milligrams per deciliter. Their PSA, prostate-specific antigen, should be less than 5. Their high sensitivity CRP should be less than 5, and hemoglobin A1C should be less than 5. 5 is a good number to remember. Read these guidelines. They're outstanding and up to date. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.